through an exam. And I always laugh at this, but what is the earliest age a child can be taught through an exam?
3.
I think your book says 2 to 3. 2 to 3. So if I ask you what is the earliest, then you would say 2. And that's laughable because there are some 2-year-olds that you can't at all, and then there are some that are, a little bit better at that. So, but if you were to ask that question, the response would be, the earliest would be considered to be 2. And then the other thing I was looking at, I mentioned it, but I don't know that we really talked about it, the Salter-Harris fracture. You may have had this when you were in your positioning class for upper and lower extremities, but Salter-Harris fractures are rated 1, 2, 3, 4. I can't remember, it goes to 5.
Depending on what part of the epiphyseal.
Yes, and that's my question. So remember how we talked about, like, what organ is the aisles of Langerhans associated with, or the loop of Henle? I think, did we talk about that last time?
Mm-hmm.
Okay, so Salter-Harris fractures are fractures of what?
The long bones.
And you said it.
The epiphyseal
Your
plates.
epiphyseal plates. So those can easily fracture in a pediatric patient. So anyway, so I just wanted to make sure you knew that.
I had one.
Mhm.
I had a fracture on my plate.
Did you really? Do you know what level it was?
No.
Okay. But I bet if you had that report, I bet it's in the report somewhere.
Yeah. That's a great.
Mm. Okay, now what, okay. I know what I'm doing. I'm so giddy that this is my last lecture. So next week is our final, or just our last test. It's on pediatric, and then myelography and arthrography together. So I think it's 25 questions, maybe 30, something like that, no more than. And
It was any guy?
other than what I just said,
Called PowerPoint.
much guess. Let's see, I want to see how many questions. 25. And so you're working on getting your 16-week eval.
Mm-hmm.
You're working on getting your fluoro orientations completed. You're working on transportation if you haven't had that before. Making sure you're logging in your exams. So by next Monday, all of that will be done. You'll have your final. And then, are you keeping track of your grades? I have a grade sheet for you in your syllabus. It's hard for me to tell you, on your final, what your grade is for the class, because I have to figure in your time from clinical. So that won't be done, well, maybe. I have your test grade final, cumulative for that. What else? Oh, and all your evaluations. So there's different components of your grade in this class. So that grade sheet, you can kind of figure out what your grade is going to be based on how many absences you've had from clinical, or what your evaluations have been. So you have an idea. When grades are posted, and what I have posted for you is different than what you thought it should be. Not just because what you thought, you kept track and it's not matching, then let me know. And I'll, we'll figure it out and get that changed. So if there are any surprises for you, and or you want to discuss your grade, not a problem, we can do that, okay, at any time. I have made mistakes inputting grades. Seems like I do it at least once a semester, no matter how careful I am. When I submit grades, they have one of those drop-down menus. So you click on the little arrow and then, A, B, C, D, F, whatever. And, I click on the A and go down to the next one, and then F gets put up in there. I try real hard to go through and make sure that that doesn't happen. So it's very frustrating for me when it still happens. It's like, what more can I do? But if that ever happens, you just contact me immediately, and I'll get it figured out and get it changed for you. I have to go over to A&R to do that, so I don't like making mistakes. I don't do it on purpose. I try really hard to avoid it. But just so you know, to contact me anytime. Okay, who has done a myelogram? That's what we're doing first. Okay, 1, 2, 3, that's it? Okay, talk to me, what do you think about that? Mr. James, what do you think about that myelogram?
That's good, it's pretty straightforward.
Did your radiologist do it?
Yeah,
And was the radiologist able to get into the subarachnoid on the first stick?
usually, yes.
Okay, good. How was your patient? How did they handle these?
Most of them are pretty good.
Okay, okay, good. And then who else? And let me ask you this, when the needle was inserted, what was the patient position? Somebody else, who else did it? What was the position of the patient when they inserted the needle? Were they on their stomach, on a pillow kind of thing?
On their belly, yeah.
Okay, on their stomach?
Yeah.
Okay, now, it's so interesting to hear different methods. The radiologists did it? Radiologists, were they good at getting in where they needed to?
I've seen so many. I had one that had to pull all the way out and then go
Yes.
back in a different area entirely. And then one guy that 2 seconds was in and
Great.
out, so.
Has your experience been good with these?
Yeah, generally it's very quick. I think one, she just had chronic pain all over her body, so hers is pretty painful. But most of them say that they don't feel anything.
Okay, that's good to know. Did they go to CT afterwards? CT? Yours go to CT afterwards? Okay. So for those, this was the very first exam I ever saw and I went through a hospital-based program. So I had an interview. They selected like there were 4 in my class, 4 students to go through this hospital training program, and then you have an interview and you get accepted and you're like, oh yay, and then you wear your uniform, you go in and they go with that person, and okay. And then I saw a myelogram. It's a wonder I even stayed. And I remember the doctor having to manipulate the needle. You know, we don't dig around.
So you fish
We
for it.
manipulate it, and here blood is running, and I'm like, what am I doing here? What did I get myself into? But myelography is, we're looking at, again, the central nervous system within the spinal cord to make sure that there's nothing wrong. And a lot of times, we're going to look at some indications for this, but we do need contrast media for myelography because you can't see the spinal cord without it. So not in normal radiography. So we're not looking at the spinal cord as much as we are, the contrast media is in the subarachnoid space, one of the layers. But when the spinal cord is structurally different, then we can see what it's doing with the contrast media around it. So the spinal cord goes from the foramen magnum from the skull to L1, and then from L1 to the coccyx is the conus medullaris. You don't need to know how long it is, but that's just to give you an idea, and how many pairs of spinal nerves. I'm just going to go through this real quick. Here are the different layers of the spinal cord. The outer, I'm going inner. This is the inner, the pia mater. This is a subarachnoid space. The question would be, where is the contrast media introduced into the spinal cord? So it's the subarachnoid space. Now we have to find a place where the subarachnoid space is large enough to insert a needle without going all the way through and hitting the spinal cord itself. You can imagine, and maybe this has happened to your patients, where the doctor puts the spinal needle in, again, the long needle, goes into the it goes into the subarachnoid space and goes a little bit further than what they want, and hits the nerve. So a patient may feel pain down one leg or the other depending on how it is. So the purpose of the cerebral spinal fluid, shock absorber, and it's produced in the ventricles of the brain. So, and then you have the arachnoid subdural space, and then the outer tough layer. Notice when they're pushing the needle in, and if you watch closely, you can see once it's pierced the dura mater, it kind of pops a little bit, because that is a tough outer layer membrane. So when they're pushing it in, they've got to get past that. And so you may be able to notice that. And then the epidural space. So I have some pictures. I don't know how great these are. This are from some other sources. You also have this in your positioning book. So both arthrography and myelography is in your positioning Bontrager book. So here is the conus medullaris, and this is where it's after L1, and this is where the spinal cord becomes smaller. Okay, it becomes smaller. And so the subarachnoid space is larger. So a lot of times the needle insertion will be anywhere inferior to L1. Okay, we don't really, they don't, as far as I know, they do not go above L1, because then the spinal cord takes up most of the, let's see, this one, the spinal cord takes up most of the space. And so the subarachnoid space, anywhere from L1 above, is very narrow. And so it's only after L1 that the needle is inserted. So what are some indications? The first one is the most common type of indication for myelography. Do you remember, those of you who've done them, do you remember what they're for?
Mine are usually for a pseudotumor.
Oh,
I've a
interesting.
bunch of those.
Okay. Okay. Mr. James, do you remember?
I don't remember exactly what the diagnosis.
Okay. A lot of times, in layman's terms, slip disc. That's where the intervertebral discs ruptures, and the annulus fibrosus herniates, or the nucleus is in the middle. It herniates through the annulus fibrosus and impinges on the spinal cord and can cause some pain. So a lot of times you'll see this on a myelogram. But any lesions, as you were talking about, or cysts, any degenerative diseases, malformations, syringomelia, cavitation of the central segment of the spinal cord. So any of these reasons would be a purpose for doing a myelogram. Contraindications, intracranial pressure, any sensitivity to iodine, although we are using iodinated contrast media, but it's non-ionic. So the chances of them having a reaction to iodine is low on this. Anytime contrast media is introduced into a space or a joint space or anything like that, the chances of a reaction are very, very low. It's when it's pressure injected into the blood system that the chances of a reaction are increased. Arachnoiditis, so this is again inflammation of the arachnoid space, presence of blood in the cerebral spinal fluid, or if they've had a puncture within the previous 2 weeks. So there was a test, and I don't know that any of you do this, but the cerebral spinal fluid is a balance of the fluid is being produced in the ventricles and runs up and down through the spinal cord, okay? And when this cerebral spinal fluid is out of balance, then problems can occur, seizures and things like that. And so we don't want to disrupt that balance any more than we have to during a myelogram procedure. So intracranial pressure will occur if there's a blockage anywhere along the spinal cord. Okay, and so a lot of times when there's a blockage and you take out cerebral spinal fluid and put in contrast media, it can disrupt that balance and cause some problems. So it may be a contraindication along with the rest of them. So again, make sure you know your indications and contraindications. What is the most common indication? Maybe an H&P. Yes.
She said a pseudotumor is why you do it. What's a pseudotumor?
Okay, it's a tumor that they don't know if it's benign or malignant, but.
Just a mass,
it's
right?
A mass, yes. But interesting that you've had multiple ones. I've seen a cyst form in the spinal cord, but, and masses, yes, but I mean, to have that, you know, to be seen, so quite a few of them. There, again, contrast media is, you know, we've talked about them before in here, and you probably have in your 162 class. Before the iodinated contrast media, they used air. So this was a problem because air is injected, and then once the patient sets up, right, the air rises to the highest point, and so they would get a headache. In fact, that's how you can tell if there's a blockage. So they insert a little bit of air through the needle into the spinal cord, sit the patient upright, and wherever the pain is where the blockage is. So if it goes up to their ventricles and causes a headache, how nice, right? Then there's no blockage. If it stops maybe at their neck level, you know it's in the C-spine, that sort of thing. So not a fun way to determine if there's any blockage. And then the air is a negative contrast media, so the patient had to make sure that their head was lower than their feet so that the air would stay in the spinal cord until it was absorbed. I know I'm old, I've been in the field forever, but I've never done the air thing, so you know. And there's some other exams for that, but before my time. We do use the water soluble. I remember when they introduced this, we always had ionic, but I remember when they introduced the non-ionic, and it was called, now it's called Omnipaque. It was Amnipaque, A-M-N-I, Amnipaque. It was the very first one, and we had to mix it ourselves, and it was just like so amazing. But with the water soluble, with your normal contrast media, it would irritate the linings of the spinal cord. It was painful. So that was a detriment to the study when the patient's in pain. So then the Amnipaque was introduced, non-irritating, non-painful, and very rapidly absorbed. So these are some of the common ones. Do you remember what you used for a myelogram?
Omnipaque 300.
Okay, Omnipaque. Okay, that's a pretty common one that is used, and it's been around for a long time. And prior to that, we did use the oily. It was very soothing. It didn't irritate the membranes or anything like that. However, any oil-based contrast media is slow to absorb. So, and it has a high persistence. And what that means is because it slowly absorbs, it's in the body for a long period of time. So I have done lumbar spine x-rays, and I see, you know what happens with oil and water when they're mixed together? You get those bubbles, and so it looked like they were shot in the spine with buckshot. I mean, it's what it looked like to me. You know, very, one thing about oil, it has a very high density, so it shows up really bright on an x-ray, and so like metal does. And so it looked like they got shot, so there were little dots all throughout. I've seen it up in the skull where the contrast media has gone into the ventricles, and so you can see it sometimes in a skull x-ray. So what they would do for a myelogram, when oil was used, we would try to, the doctor, the radiologist, or the neurologist would tilt the patient on the table to where all the contrast media is in the level of where the needle is, and they would suck out the contrast media. Of course, they couldn't get all of it, so there would still be a little bit of oil left in the spine. And so this is what was used. This water-soluble, very irritating and very painful, and can cause irritation. So that is why you want to be careful. Do you just use Omnipaque for everything? Do you have different contrast medias for different exams? Because if you do, you need to always, and I cannot emphasize this enough, you need to be careful about what you're pulling out for what exam. So you have your contrast media located wherever, And I don't know, what happened to one of our students, and this is again, when we did a lot of kidney studies with contrast media, the IVPs, and, Conray 60, or any one of those, ionic water solubles. So they're in a cabinet, and every day this student was preparing the syringes for all the IVPs and going to the cabinet and getting the Conray every day. Now here comes a myelogram. Guess what the student did? Went and got the Conray and set it up. The tech was in there, the doctor injected it, and the patient had seizures, a lot of pain. It was a big mess. And so who's at fault there? Everybody, absolutely. The student, just because you're a student doesn't negate your responsibility. And they settled out of court and that sort of thing, or they settled somehow. But you just need to really pay attention when you're grabbing any contrast media. What do they call it in the hospital, where they stop and verify your name? Timeout. Take a timeout when you get your contrast media. So you pull it off the shelf, and what are some things you're gonna do?
Read the expiration.
Expiration date, and then check. Just take a moment and make sure, okay, myelogram, omnipaque, okay. And just take that extra second to confirm. A radiologist, I don't know what you do when they inject. Do you have the bottle handy for them to look at?
Show it to them before they.
Before they inject. I've had a wide variety of radiologists. They're like, get that out of my face. I'm like Vanna White or whoever, here it is, and they're like, I'm like, okay, but at least I did my job. I'm showing them, if they choose not to look at it, that's their problem.
Yep.
But I always make sure, or whatever your protocol is, or if you have a tray and you set it near there or whatever, that it needs to be not thrown away until after the exam is over in case they have a reaction or whatever. They're gonna want the lot number, the expiration date, and that sort of stuff. So it's a good habit to get into, to show the radiologist what contrast media you're using.
That's your
So as I said, the oily has to be removed. This, the non-ionic, does not show up as bright on the image as the oily does, and it starts becoming absorbed, it starts losing its radio opacity quicker. So you can't dilly-dally around. You've got to get these images, or the radiologist needs to get the exam done sooner rather than later, because the brightness of the contrast media is going to decrease. You're not going to be able to see. So the oily, we use Pentapaque, which you're not using oily anymore. Just kind of the history of the contrast media. Patient prep, or the pre-procedure, and see how this goes with what you're doing. Of course, explanation and consent, sedative or not? Maybe a Valium, do you know? Okay, sometimes they may be given some pre-medication, maybe not. That's between the doctor and the patient. We want full hydration, so we're not MPO for 8 hours like we have been before. We want full hydration. What's the purpose of that? We used to not do that, but we have found since to drink water and to fully hydrate reduces the side effects that we're going to talk about next. However, they do want MPO 2 hours before the exam. Do you know why? Anytime it's a short MPO period, it's just that they don't want anything in their stomach in case they throw up, and they may aspirate. So you can imagine, throwing up with a needle sticking out of your back, or aspirating during the middle of a procedure. So they just want the stomach empty, so in case the patient feels nauseated, then they don't aspirate. And the neuroleptic drugs are discontinued. This myelogram, again, you're disrupting the cerebral spinal fluid, and so that can send somebody into a seizure, possibly. And so if they're on neuroleptic drugs, that lowers the threshold for seizures occurring. So it's kind of a tricky combination. So some of your hospitals, I think, who's at Saddleback? Okay, I don't know if it's before or after. Some hospitals do 48 hours before, 2 days before, and 2 days after discontinue those drugs. Some are just before and some are just after. So everyone has a little bit different protocol for that. But the neuroleptic drugs do need to be discontinued either before or after if the patient is taking those, only if they're taking them. So I'll ask you this question, what are some of the side effects? And so there you are, the nausea and the vomiting. So if they have something in their stomach, they're gonna throw up in my room. I just don't want them to throw up anything but bile or gastric juices. So this could be, headaches could also occur, and do frequently occur. Bleeding, any infections due to the needle being introduced into the spinal cord, as I've said before, seizures, and arachnoiditis. So kind of the same thing, infection, arachnoiditis, are some of the things that can happen. And so that's what we want to do, is lessen the side effects occurring. So hydration will help with those. After the procedure is just important also, as it is pre-procedure, and that we want to keep the head elevated slightly, not in an upright position. When you wheel them out of the room, do you prop maybe some extra pillows up underneath them? They lay flat? Flat?
Well, sometimes they actually put the bed so that the feet are a little bit up because they want the contrast to go like up towards the head.
Okay, Mr.
I've had that
James?
happen twice already.
Okay,
We had a slow progression of the contrast, so we actually had them bent down.
Okay,
Well, we had
interest-
them strapped into the table, and we had them,
okay, no, I'm talking about, when they're off the table.
yeah, that too.
Yeah,
The
we have
bed-
a
on the
pillow, but
frame.
we don't like go and like try to prop them up.
Okay, well, it's interesting, because we don't want the contrast media typically to go into the ventricles, especially during the procedure. During the procedure, if the contrast goes up into the ventricles, it's not coming back out anytime soon. It's not like the blood system that circulates through like this. So once the contrast media has gone up and trapped in the ventricles, it doesn't matter if you stand them upright or not, that contrast media is not gonna come back down into the spinal cord. So check with that and make sure, I mean, if that's what you're supposed to do, then that's fine. Maybe they want the contrast media to go up into the ventricles for a CT scan with contrast media, I don't know. Typically, the head is elevated just a little bit to keep the contrast media. It's heavier than the spinal fluid. Contrast media is heavier than the spinal fluid, and it'll stay in the spinal cord if their head's slightly upright.
The only reason we did that is we scanned them probably 3 times in a matter of 20 minutes to see how far it progressed, and it wasn't moving, so
Oh, okay.
that was just to help.
They
it
were
get
trying
it.
to move
Yeah.
it. Okay,
Yeah.
got it. Okay, that makes a little bit better sense. And like I said, everybody's a little bit different. I mean, and it depends on, sometimes the contrast media, because amnipake, we did not elevate at all. We kept them flat. So it might be the contrast media and its effects as to what you might do. But typically, head elevated a little bit just to keep the contrast media from going up into the ventricles. And then after that, the patient needs to be supine, and it says for the next, couple of, 16 hours it says with BRP. Do you know what that means? Bathroom privileges. So in other words, they want them quiet. Again, we've disrupted the spinal fluid. And so we want to have the patient a little bit quiet, but they can get up to go to the bathroom and come back to bed and lay flat. So again, just depending on your hospital and the doctors, hydration is suggested just to replenish that cerebral spinal fluid that was disrupted, and then of course a regular diet. They are not restricted with their diet any more than they were before. A lot of times, patients after our exams would have headaches. And so they have found that keeping them up a little bit is from the disruption of the cerebral spinal fluid and the contrast media. So if you can keep the contrast media out of the brain area, then that is helpful.
I heard caffeine helps with that too.
Caffeine
Yeah.
with the hydration,
No, with the
headaches?
Yeah, because I had a lumbar puncture done,
Uh-huh.
and I had like the worst headaches of my life, like following that procedure. And then they told me to drink caffeine, and once I drank it, like the headaches were gone.
And that's probably because the caffeine constricted the blood vessels and you weren't having that throbbing, you know.
Yeah.
Interesting, great, good to know. Have a cup of coffee, have some iced tea, have a Coca-Cola. Okay, thank you for introducing that. Puncture method.